Okay, Assalamu alaikum wa rahmatullah. Good evening, dear colleagues and friends. Welcome to one of the meeting for weekly meeting done by NIOM Academy. And today we are proud to have a very eminent speaker for us. They are going to tackle the keratoconus from A to Z. So, and they will talk about what we need to know about keratoconus. Dr. Osama Al-Jaledi, he will be the moderator and speakers, and we are honored also to have with us Dr. Lucio Maranjo from Brazil. Thank you, Dr. Lucio, for being with us. And we apologize that Dr. Safan, he will be not able to join us as there is a familial issue, and he will be soon, inshallah, in other meeting. And we are having also my dear friends, also Dr. Muhammad Imad Adil. So Dr. Osama, if you want to start, or we can give us 1 minute, just we will show one video before that, then we can handle the mic to you, please. Okay, so yeah, if you can share the screen.
Hi, I'm Dr. Şengül Özdek. My primary interest is retina with retinal surgery and specifically pediatric retina, including ROP, PFV, fever, codes, Stickler, and the others.
Hello, I am Dr. Sri Ganesh, a well-known ophthalmologist from Bangalore, India. I specialize in cataract, refractive surgery, and presbyopia treatments.
Hi everyone, my name is Dr. Jorge Rocha. I'm from Brazil.
And I'm honored to be invited to speak at the prestigious 5th Middle East Ophthalmology meeting.
I am attending and presenting at the 5th MEOM conference and the 1st Pressmania conference in Dubai.
I'm here to invite you for a very important meeting, the 5th MEOM and the 1st Pressmania meeting that's going to be held in Dubai next October.
Don't miss this incredible opportunity to learn and grow with experts from all around the world. Hope to meet you at the conference.
Come and learn from the experts there, and hope to see you there.
It will be a great opportunity to meet many friends and specialists from all over the world. I hope to see you there. Bye.
Okay, thank you very much. We'd like now to handle the mic to Dr. Osama. Please, if you can go ahead, please. Thank you.
Good evening, everyone. Thank you for joining us for this meeting. We're going to cover different aspects of keratoconus. And it's a pleasure to introduce Dr. Lucio Maranjo from Brazil. He joined us from all the way. We're going to talk about introduction about keratoconus, the prevalence, and then we'll cover different aspects about cross-linking the cornea ring and the different modality. And we're going to discuss about different options and different management about the keratoconus. So it's really a pleasure to have Dr. Lucio with us, and looking forward for his talk. And he can share his presentation, please. Dr. Lucio, can you hear me?
Yes. Hello, Dr. Lucio, can you hear us?
Thanks so much for this opportunity and talk. You see the screen?
Yes.
Yes, no, it's okay.
Yeah, that's fine.
That's fine. Okay. Let's talk about the introduction and diagnosis in keratoconus. And so when I started ophthalmology a long time ago, yes, when I just learned the 3 criteria, Rabinovich criteria, that when the patient should have these 3 criteria, the K over the 47.2, or IS, the asymmetry, over the 1.4. And if you have the different K difference between the eyes over the 1 dioptry,
I think we have lost Dr.
Yeah, I think he's joining back again now.
Maybe there is some issue in the internet.
That's okay?
Yes.
Yeah, we lost you, Dr. Lucio, for a while. So if you can just reach here again and start from the beginning, yeah. Because there is an interruption in your voice.
Okay, okay, I know this. Well, when I started again, when I started in ophthalmology a long time ago, I just learned 3 criteria to diagnose keratoconus that were the Rabinovitz criteria, just like the K over the 47.2 in the keratometry, or IS, the asymmetry, over the 1.4.
Can you share the screen, please? The screen is not shared.
Oh, I will share again. Let me put here. Let me see here. I'm not finding.
Okay, take your time, no problem. Just.
Okay, I just found it here. Okay, I will solve this problem now. That's okay. Okay, hear the screen? Hello, that's okay?
Yes, we can, but still we are having a facing problem of internet, maybe from your side. Let us try now again. It's okay. Now I think it's okay.
I think it's okay. Can I go?
Yeah, please go.
Yeah. Okay. So as I told, the Rabinovitz criteria were 3, K over the 47.2, IS 1 over the 1.4, and the fellow eye, the difference K over the 1 diopter, we should diagnose keratoconus. But the time has changed, yes? And I leave this question here. Is there anything beyond just the numbers nowadays? Of course, a lot of things, né? We should put together, if the patient comes in, show a decreased best corrected visual acuity. If I find in the patients a high amount of astigmatism combined with myopia, I should suspect of keratoconus. I should analyze the abnormal, sometimes pachymetry curve. Have nowadays some inflammatory markers on the tears, yes, tomography index, a lot of things, corneal topography image that I can put together to make maybe easier the diagnosis of keratoconus, yes. But we have the Krushmets classification, keratoconus classification, which is goes from the stage 1 until 4, that it relates more than the numbers. Yes, we can find here consideration about refraction, about the mean K, about biomicroscopy, scarring or not in the cornea, pachymetry, and then we can classify the keratoconus. More than this, beyond this, we have a morphological classification. Yeah, just like the Fernando Vega Alfonso, in the shape of the keratoconus, yes. Just like the croissant pattern, a duck pattern, a snowman, a nipple, or a bow tie. And when we put this together, we can decide the better treatment for the keratoconus. It depends on the stage, yes. The patient can use glasses, contact lens, crosslink, or intracorneal rings, Bowman, Dowk, or even a PK. But our biggest challenge here in diagnosis is not case like this, because we can see that's a huge keratoconus here. Our biggest challenge is the early keratoconus, to diagnose in the early keratoconus stage. Just like example like this. If we follow just the numbers in the colors, that's okay. It's below the 47, yes. and the colors are great, but the image shows something strange here, the asymmetry, yes, in the morphological classification, just like a duck here. That's the point that I want to talk a little bit, because today we are living a real tsunami. Yes, we have a lot of patients searching to take free, to get free of, to be free of their glasses because of this here. The increase in myopia in the world. Nowadays, we have a longer patient survival about the age, and many types of different refractive procedure with more accurate procedures. And patients search to be free, yes. And I want to talk about the importance of analyzing the image. A step before of a real keratoconus in this. Maybe that stage, in the early stage, that I want to talk a little bit now. This paper was published in 2006 by Bradley Herendman. Yes, it's important to say here that at this time, PTA, personal tissue alteration, did not exist yet at this time. Yes, and she showed two cases that the patients underwent PRK, yes, and analyzing the topography in that time, in that area, we can see here the numbers okay, the colors okay, but something strange again in the image. And underwent to PRK and developed ectasia. The second case, they show the right eye, in this case, the left eye, and this is the most, for me, this is the most dangerous pattern of image that tricks some surgeons. Yes, because it shows regular astigmatism, a symmetrical astigmatism, but we call here a baby bow tie. Yes, and this is it's hiding the keratoconus here. Yes, that's the problem, because the patients in the second case underwent to PRK and developed ectasia. But okay, someone now could say, but you may say the cause was the amount of the ablation, not the image. Yes, it could be a possibility, this, yes. But if we see this paper here, that nowadays we can mix and combine the PTA and image of the suspicious topography, combining these two factors, what's the whole in ectasia? We have this paper here. And so this paper divided in three groups. The first one with normal patterns or mirror asymmetrical steepening, low than a half dioptry, low suspect patterns, asymmetric bow ties between 0.5 and below than 1 dioptry, and the high suspect patterns inferior, which have inferior skewed, plus IS, or just asymmetry over the 1 diopter located in the inferior steepening. And it shows something interesting here, yes, because when we combine the PTA in analyzing the suspicious keratoconus with altered, modified images, yes, the paper has shown that the higher is the suspicious, the lower is the value of the PTA, yes. So if you have low risk, it decreases the number of PTA. If you have high risk, if the image, the number is not 40, but it's less, 29, 32. Yes, that's interesting. Yeah? And the paper shows that abnormal corneal topography has been shown to be the most robust risk factor for postoperative ectasia. And showed that the PTA was high, 45%, over the 40, for eyes that developed ectasia with normal topography patterns. This value decreases significantly in eyes that developed ectasia with more suspicious topography patterns, which I said, the numbers below than 40, 46, yes. And the PTA showed that was significantly associated with the development of ectasia in eyes with suspicious topography, in eyes that developed ectasia. It shows that it doesn't mean that if you go overtaking or exceed the value, you will have ectasia, but at least you will increase the risk of having ectasia, yes? And these two factors, PTA and the altered or modified image in the early stage, it's dangerous to indicate, for example, around refractive surgery, yeah? This patient, I want to bring this case I received this week in my office here. Yes, these patients came and complaining about the vision in the left eye. We can see here the numbers, okay, but we have much more than numbers. Yes, we have the image. And the patients had 20/20 in the right eye, but complaining in the left eye with 20/30. pH 20/20, and we can see here one image in the early stage. We can call a frustrous keratoconus here, yes. And the second case that I received this week here was this one. The patient wants to be submitted to refractive surgery, and I saw the right eye, and now that's the dangerous type. Now the baby bow tie here with huge variation of the colors, and the patient has a beak here, yes, in the left eye, one asymmetrically with the great variant of the colors in the scale here, yeah, 20/20 and 20/20. Of course, I didn't indicate the refractive surgery in the surface, and indicating a fake IOL for this case. But what's new in keratoconus diagnosis today? We can bring here a epithelial map, yes, and I will indicate you to read this paper that's very interesting from Marconi Santiago. Yeah, that's the numbers was 150 eyes that was divided in 3 groups: 50 with progressive keratoconus, 50 with stable keratoconus, and 50 with normal eyes, a group control, yes. And the epithelial map is so important, maybe in the early stage to diagnose a keratoconus, because it makes a significant difference here when comparing the control groups and the progressive keratoconus. The average, the difference of the minimal and maximal thickness of the epithelium, we had a significant difference between the control groups and the progressive keratoconus. Yes, in this table, comparing to the pachymetry, yes, the pachymetry map, when compared these both groups, just stable keratoconus and progressive keratoconus, in the stable one was significant statistical difference in the standard deviation, but in this epithelium maximum thickness, in epithelium minimum and max, the difference, the variation. But when we go to that progressive keratoconus that's getting worse the vision, yes, was significant in epithelium minimum and in the epithelium inferior. It means that it's very interesting that the thinnest part of the epithelium follows the steepest curvature of the cornea. When getting worse in that area, getting steeper, the epithelium should be thinner in that part. But as we know, in the whole cornea, the keratoconus is irregular, and we have some flat areas. In the flat areas, we can have above this area in the stroma a thicker epithelium thickness, yes. And although of the thinnest pachymetry in that area, in the flat ones, but in general, the thinnest epithelium measurements, yes, follow the thinnest pachymetry in the steepest curvature in that area. As we can see here with this image here, we can see the steepest area here in this image, and follows the thinner in the pachymetry here in the thinnest part, and the map in the epithelial map here following the same area, yes. And in progressive keratoconus, we could find the great variant of minimal and maximum difference in the progressive group, yes. Well, looking to the future about the diagnosis, we have nowadays some three paths, three ways, yes. Some new inflammatory markers that we could find in the tears, yeah, in the surface, in the eyes. I think it's one way that many that is wanted to study, yes. The second one is the artificial intelligence. I think is the future real one that could mix and combine so many images from tomography, so many index in tomography and image in topography, and combining all of this image, we could maybe detect or define an early stage of diagnosis in keratoconus. And the third part is the genetics studies, genetics treatments, that we can find some other genes linked with keratoconus. That maybe achieving some score, we can predict, yes, or prevent more these patients about the disease, yes. Well, finishing, I would like to invite you to our DMEC course, yes, theory and practice, that will happen here in Recife. In the theory, we have slides in English, and the practice here in Recife with wet lab with human corneas, brainstorm, and live surgery. Well, thank you so much for your attention. It was my pleasure to be here, okay? I give the words to the coordinator.
Thank you very much. That's a very interesting talk, and it's very useful for all of us. For this participant, if they have any question, please can you put it in the question in the QA, and we can ask the speaker, Dr. Lucio. Regarding the, it's interesting as you say about the two things. About the first of all, the inflammation. Now we know there's inflammation play important role in keratoconus development, and the eye rubbing, which is in our area, both of them is a higher level, and we had a higher level of keratoconus. I'm not sure what's the prevalence in keratoconus in Brazil.
So, sorry, interrupted. I stopped.
In our area, in Middle East, is really the prevalence is very high now. Is much higher than expected before in the Middle East. And I'm going to give one in the presentation. I'll put one slide about how much prevalence in our area. How is the prevalence of keratoconus in Brazil? Is it now is higher than estimated before, or?
Yes, it's a good question. I think it's a little bit higher, yes, than we found before, because not just in Brazil, but in the whole world, we're more exposed to the screens and all of the being exposed to screens. We can have dry eyes, inflammation, and rubbing, and atopy. Yes, and it's another time today, and I can find here a little bit more prevalence of keratoconus in comparing in 10 years ago or 20 or 15. Yes.
Dr. Lucio, thank you very much for your nice lecture. I have one question here.
Thank you.
Which kind of markers, inflammatory markers, it looks like would be relevant in this case?
Yes, you're talking about in the tears that we can find inflammatory markers?
Yes, which kind of markers? For example, we are familiar with the MBB9 for the dry eye, but if there is any new markers for which is connected to keratoconus?
Yes, I read a paper that's one very strong link with keratoconus, interleucin 8, yes, and another one is CC5, yes, that we can find. But it's not just, we most thinking in these two factors now, because not just the marks inflammatory linked with keratoconus, but we have still in dry eyes that cause some rubbings, yes, in atopy. And the patients sometimes don't have genes or inflammatory markers linked just to keratoconus, but develop one dry eyes and start rubbing the eyes and develop in secondary the keratoconus. But specific in keratoconus with inflammatory markers, interleucin 8 and CC5. that I've read. Yes,
Thank you. Thank you for your answer.
no, you're welcome. My pleasure.
Any question from the audience?
Can I have some comments here? In the last few years, we had in the market now the Corvus, which is the first application of artificial intelligence, which is using the Gamble Forest program to link the indexes of the biomechanics with the indexes of the corneal topography to get up with the TBI index. Any other attempts, as far as you know, to use artificial intelligence in improving the diagnosis of keratoconus, apart from the Corvus?
No, I don't know deeply about what is developed about artificial intelligence, but I really believe that is the future. Yes, it's challenging to put together all of this information index in so different types of image, but I think it's possible in not a future so far from here. I think the next 5 years or 7 years, we're gonna really have some tools, yes, that will, not just for keratoconus in anterior segment, but in other parts of the eyes, retina and glaucoma, that will, with artificial intelligence, we're gonna expose for us ways to diagnose earlier the disease, so many different disease. Yes, I think that's very close this future now.
Totally agree with you, Dr. Lucio, that we are waiting in the next few years to see some more advancement in artificial intelligence application to assist the ophthalmologist in putting the diagnosis. Thank you for your time, sir.
Thank you.
Yeah, pleasure.
And so I think I will share my screen, and basically what I'm going to talk about the treatment option for keratoconus. My talk basically mainly about cross-linking, and so Dr. Safan supposed to give a more talk about other modality, but I will cover cross-linking and intercorneal ring for my talk. I'm not sure, can you see my screen there?
Yes, that's okay.
Yeah. So basically, is it move? Is that right?
Moving, yes.
Yeah.
You are
So
okay.
the etiology about keratoconus, just briefly about keratoconus, it's a multi-factor integrated together. That's why people create keratoconus. The hereditary factor, eye rubbing, atopy, and inflammation, and the environmental factor all together, that's predisposing to keratoconus, and that's we need, especially the eye rubbing is really very important to educate our patient to stop eye rubbing, because that's very, if someone had hereditary factor with eye rubbing, definitely will end it with keratoconus. The other things which I want to highlight about the prevalence in our area, really the prevalence is much higher than previously thought. It's before talking about 1 in 2,000, but going to like a study in Lebanon, we're looking 16,800. So the prevalence in the pediatric age 0.5, but with adult more than 14 years, it was 3.78 people had keratoconus. The other study in Saudi Arabia 2018, the prevalence found at 4.78. The other study also in Saudi Arabia and Taif, look at people coming for laser surgery, and they do screening, and they found that 8.6 they have keratoconus. Our Cleveland clinic 3 years ago, they did a study in the secondary school, looking to the secondary school in Abu Dhabi, from 239 students, aged 10 to 19. So 2.7, they have keratoconus, and a typical topography, it was 19.8, which is the high, and there's some of them even will develop keratoconus later on. So really the prevalence is very high. So we need to have very low threshold to diagnose keratoconus in our area and everywhere in the world, I think. Regarding the management, basically there's two aspects. Improving the vision. So if it's detected early, the glasses could be early good enough. If it's not glasses, then you need to have clearer contact lens or rigid contact lens. The other modality to improve the vision, intercorneal ring, phakic intraocular implant, or topo-guided BTK. The second thing is to stabilize the keratoconus. If it's not stable, we do cross-linking to stop the progressive keratoconus. We could use the rings, but that's mainly to improve the shape. But if we're concerned about stability, we need to do cross-linking. And in advanced stage, which at this stage, all what we do now detected the keratoconus early to avoid to reach advanced stage. So hopefully in the future, we shouldn't see any patient reach advanced stage of keratoconus, because it will be life change for this patient. So once it's the advanced stage, we're talking about cornea graft. Usually we do DALK, but sometimes we have to do penetrating keratoplasty. There's in the middle range, you can do Bowman's layer transplantation. And there's a patient with advanced keratoconus, you can develop acute eye drops, and the option you could do injected air in the AC. And one thing in the last meeting last week, some people using DMAC graft, small one, use a DMAC graft to close the acute eye drops as one of the management and suture to help to improve the eye drops recovery. Regarding, mainly now I'm going to cover about the keratoconus, cross-linking management. Basically, cross-linking is basically using ultraviolet A radiation with the riboflavin that interact together and increase the strength of the cornea. And it's almost like 3 to 4 times the strength of the cornea. So basically that prevent the progressive keratoconus. And really is a big game changer in the management of keratoconus. The first was introduced by Tayo Seiler, 1997. It takes 9 years for FDA to approve it. So in Europe, we have done a lot of cases and then recently that FDA approved it. And now gold standard for stop the keratoconus progress to do cross-linking. The protocol which initially adopted the Dresden protocol, which is most of our familiar with. So using 3 milliwatt over 30 minutes. But after that, there's variable different protocol. We try to do it faster. So people start to reduce the time to 10 minutes, then 5 minutes, then 3 minutes. But the meantime, you increase the energy. But they found it by making the shorter high energy may not be as the same effect. So that's why we went back a little bit. No one using 3 minutes anymore, but they're different modality. So regarding the protocols, the standard, as we mentioned, there is the protocol. Because we're using 30 minutes, so the duration of the treatment is too long, and the concern about the complication, and sometimes we over-treating this patient, they may develop more haze and even more flattening, and can progress over years, this flattening. So sometimes it's not good result when you had too much haze and unnecessary too much strong cornea. That's why people develop different type of what we call accelerated cornea cross-linking. Basically what you do, there's a relationship between the degree of photoreaction proportion to the total energy. So total energy is constant, but you increase the duration or reduce the energy, so it's going together. However, when they did it fast cornea cross-linking, they found the oxygen is important role. So they found that when you expose the patient to high energy cross-linking, the effect of the cross-linking stiffness is less because there's no much oxygen. So from that, we are aware that oxygen is very important. So to improve that, they did two ways, either using a pulse, so using energy of the ultraviolet in a pulse way, just to allow some time for the oxygen to come. The other option also to use oxygen mask to give it a high concentration of oxygen while you do cross-linking to compensate to have better cross-linking. Regarding the type of cross-linking, the traditional way and the standard of what we call epithelium off. So basically we remove the epithelium using then riboflavin and do ultraviolet. The other modality, it's epithelium on. So we leave the epithelium, but the epithelium generally is a barrier for the penetration of the riboflavin, but also reducing the oxygen penetration to the anterior to the cornea. So to improve that, one of modality they call ionophoresis, so using electric current to enhance the riboflavin penetration. And the other modality is what you call riboflavin, new modality of riboflavin, they call second generation riboflavin, which is basically allow the riboflavin penetrate better and better oxygen penetration also. And that may eliminate the need for the oxygen mask and the ionophoresis. Regarding the standard cross-linking, as we say, we do more cross-linking, so it's a good for advanced disease because you have more stiffening effect and achieve maximum stopping the progress of the disease. The other modality, accelerated cross-linking epithelium, the advantage of that really is shorter. You know, when you do surgery, like 30 minutes is very long for the patient, but it really is for us doctors, it's a long. But by doing accelerated, there's a concern that it may not have a strong cross-linking and slightly associated with high risk of failure, especially with the pediatric age. So the epithelium which is that what most of people doing, is more predictable, but there's a concern about, because you remove the epithelium, you worry about infection, there's a more about subepithelium haze, sterile infiltrate, or activation of the herpes epithelium. The advantage really, because you don't remove the epithelium, it's more comfortable to the patient, especially with the new riboflavin. The initial riboflavin is they're using too much chemical, so too much irritated to the epithelium. So most of them, they ended with very regular epithelium, they have pain. But the newer modality, they're promising that it will be much better in the epithelium and would provide better comfort. And because the epithelium barrier is still there, so you don't worry risk of infection the same. However, the results so far is very variable. And because you leave the epithelium, basically, which is almost 50 in a keratoconus is thinner, like 40. So that thickness of the epithelium, it doesn't go the same thickness, the depth of cross-linking. So technically, you have less cross-linking in the stroma equal to the thickness of the epithelium of that patient. So which patient we need to do cross-linking? So very important, really. Not every patient you diagnose with keratoconus do you do cross-linking, especially people coming for refractive surgery. I have patient 30, 40 years old. I did topography. I found keratoconus. Shouldn't go straight to do cross-link. So basically, cross-linking for a progressive keratoconus. If someone had a progressive keratoconus, which can be evident by topography, or if someone had their glasses changing every time, reading changing, especially with the stigmatism. So that's more likely it's a progressive. But pediatric keratoconus, most of the pediatric keratoconus nowadays considered as a progressive disease, and usually we do cross-linking. The standard criteria to do cross-linking, you need to have a good thickness of cornea, more than 400 micron, to protect the endothelium. But there's a new protocol which you can use cross-linking in a thinner cornea. And the keratoconus should be, if there's someone have keratoconus and they have a scar and the vision is not good, if there's no vision potential, there's no point to do cross-linking, because this patient needs a cornea graft. So you shouldn't do anyone cross-linking, and you know that this patient is not going to see better and you need to cornea graft. So regarding the patient with the thin cornea, there's a different protocol. As you know, when you do cross-linking, there's different factor, either the thickness of cornea. If it's thin cornea, you could swallow the cornea. Riboflavin concentration, most of the study, they fixed that, but now they can changing what you call ultraviolet and the duration for patient with thin cornea. So going through the first one, the thickness, increase the thickness. One option you could do, you could use hypotonic riboflavin. So when using hypotonic solution, so the strobe expand thicker, so that will give you a thicker cornea before you started the ultraviolet treatment. The other modality, what you call contact lens assisted cross-linking, basically what we do, which is published by Suzanne Jacob. So basically, we're using contact lens, we soak the riboflavin, and we put it in the cornea before started the treatment. So that contact lens soaked with riboflavin, it worked like extra tissue, but because of the contact lens, it will reduce slightly the effective of the cross-linking. The other modality, they call customized epithelium debridement, instead of removing the epithelium all around, so we keep the epithelium in the center with the thinnest area. So that will give us extra thickness to protect the endothelium. But because the penetration is different for the ultraviolet, so they have different variable depth for cross-linking. Mozarto is presented what you call M-nomogram, which is basically what he did. He looked into the studies for different study, look into different power, different energy, and look into the demarcation line, and taking in account to add 50 micron extra for the demarcation line. So, and they have nomogram, so you can choose the energy and the duration of the treatment according to the thickness of the patient cornea. And that's but you need to have a machine which allow you to choose the duration and the energy of these protocols. Hafidi, 2 years ago, presented another modality, what you call variable time duration. Basically, what he look into that, look into this, anyone who has standard machine using 3 milliwatt. So, and after soaking the cornea with riboflavin about 20 minutes, so you can choose the duration of time. So the energy is the same, but you set the duration needed for this particular cornea. So it can be treated up to 120. But you know that the more thinner cornea, maybe the effect of the cross-linking will not be as the same as someone had thicker cornea with longer duration. Younger patient, as we say, younger patient really, a lot of studies show is very safe, effective to stop keratoconus in pediatric patient. The general consensus now everywhere that any patient, pediatric age, had keratoconus need to do cross-linking as soon as possible. And that's very important because if we don't, they tend to progress very fast. And there's one study, even the patient who had cross-linking, 24% after cross-linking in young patients, they may still develop progressive keratoconus again, and they need to repeat cross-linking. Very important, which is also need to remember with any patient with keratoconus, but younger patient more, is to treat the atopy and the inflammation and avoid eye rubbing. So very important to educate your patient about that to prevent the progressive keratoconus, even if you do cross-linking. So make sure that the patient understands cross-linking helps to stop the disease, but you need to stop the inflammation and eye rubbing, because otherwise if you keep rubbing your eyes, even if you do cross-linking, it tends to still progress. So age is a predictive factor for progression. So young patient tends to progress more, as we standard that most of the patient above 40 is unlikely to progress. Very rare they can, but anyway, with age we get natural cross-linking. So which is the one advantage with age. Younger the patient, more likely to progress, as we say early, and really better to treat them sooner. Any patient with keratoconus, really is our job to educate the patient and the family that any patient had with the family, they have astigmatism, atopy, eye rubber, they need to be checked and to do topography to make sure that we don't miss early keratoconus in the family. Regarding if the other eye, anyone had keratoconus one eye, we need to make sure we watch the other eye, because keratoconus in general is a disease affecting both eyes, although it could be asymmetry. And so very important to follow the other eye, because one of the study, almost 35% people who's normal, after time, the other eye which normal develop keratoconus and need treatment. So we shouldn't miss it. Cross-linking, one advantage is stop the disease, but there's a potential that, like this patient over 2 years, that can have some effect, they can have some flattening effect, improve some of the corneal curvature. But always I tell the patient that our job for cross-linking to stop the disease, still we need to other modality to improve the vision. But other important factor which happened to one of my patients, I diagnosed him with keratoconus, we book him for surgery, and then the patient is still busy with life and he didn't do cross-linking. So he come after a year, and there's a big change in his refraction and the corneal shape. So, and the big difference from a year time, and that's really, I felt sad that how patient instead of he managing well, he could have glasses. Now his keratoconus progressive too bad that the vision not as good. I need to depends on the contact lens. So that's a big change from just patient wearing glasses, and if he did the cross-link at that time, now to become very advanced keratoconus and become different management. So it's very important to select the patient. And one thing, we shouldn't lose the patient. If someone booked for keratoconus for cross-linking, I think if he didn't come, I think after a month we need to call him and remind him about the surgery, not to lose him, because people sometimes keep you busy with life and forget it, and they come to you very late. The other modality, which Dr. Safan, I thought he will talk about today, but I'll cover briefly about it. Cross-linking in general, we're using standard cross-linking all over the cornea, but there's a new machines and new ways that we could do cross-linking, what you call custom-made cross-linking or photorefractive instrument cross-linking. Basically, what we do, we can using topography guided cross-linking, so we do cross-linking more in a thinner area. The purpose of that to improve the symmetry and improve the shape, not only stiff the cornea, but improve the shape so that the patient can see better. It's still, it's early stages. Still, we need more studies and maybe better machine to do that. And maybe that's one of the future of treatment. Some people using the epithelium removal as a simple way to do topo guided. So removing the epithelium more in the area with the thinnest area. So you had more cross-link in that area. The other modality, what you call topo guided photorefractive keratotomy with cross-linking. So basically, a patient with keratoconus, as we say, we do cross-linking to stop the disease. But if the patient cannot see clear with the glasses, and you know that is not comfortable with contact lens or intolerance to contact lens, this patient, by doing cross-linking alone, he will not be happy still with the vision. So for such patient, we could do what you call topo-guided BRK. The aim of that really to improve the shape of cornea, to improve the vision with the glasses, not to get rid of the glass, but improve the shape. But there's a concern about the haze. If you're removing corneal tissue from someone keratoconus, always you worry about it can make the keratoconus progress. So that's why we need to do cross-linking. Shall we do it the same time or sequential? Some people do it the same time. Some people do cross-linking first, wait 6 months, a year, and then to topo guided. But majority of people now, they do the topo procedure together. The first protocol for this combination, they call Aten protocol. And thanks to Canelobus who presented this protocol, and last 5 years he published 10 years result for his patient. He did it long time ago, and really the results show that is very good. Show 94% of his patients show no progressive keratoconus, and no one eye lost one line best corrected visual acuity. The protocol in generally, so we're looking for a patient with mild to moderate keratoconus, but the thickness of cornea should be more than 450, and the maximum ablation we remove is 50 micron. Nowadays, most of the people using topo-guided treatment, they're using transepithelium. So using the epithelium as a mask, that show a better result by doing that than removing the epithelium manually and then do topo-guided. And some people also advocated, yes, you can do BTK only. If you do BTK only, like 50, 60 micron BTK, and using epithelium as a mask, that's alone, it can improve the shape of cornea and improve the vision of this patient, even without doing topo guided. So just BTK using the epithelium as a mask, that the potential then also can improve the vision of this patient. I'll go to the next one, but I think I'll then do the discussion all together. The other modality of the treatment, what you call intracorneal rings. So basically, as you know, the keratoconus, there's a symmetry or bulgy cornea. So by adding a rings outside, that can improve the shape of the cornea. And there's usually we do it for stage 1 to 3 when there's no corneal scar. So if there's no corneal scar and the patient cannot see clear with contact lens and the glasses, then there's a potential we can use intercorneal ring to improve the shape of the cornea. And there's different ring thickness, diameter, segment. The most commonly using rings nowadays is Ferrara and Kira ring. You can use Intact SK, and some people use the Mayo ring. I don't use it personally because you have to, because a closed ring, so you have to dissect at the center. So, and that can creating haze, so I don't like to use it myself. And but as I mentioned, Kira ring, Ferrara ring, they have different design, which can give a different range for our patient. The technique is very simple. So basically, we're using either manual, but nowadays we're using a laser. So using femtosecond laser do the tunnel, which is very precise, very safe. We can choose the diameter of the tunnel, the width of the tunnel, the centration. So really, it has reduced the risk of the manual technique for intercorneal ring. So as I mentioned, it's very simple. Just you mark the center of the cornea, and then basically you just using femtosecond laser to do the tunnel and the opening. So really, surgical is much easy. And you don't need to have very wide experience. It's very simple. With most of the surgeons doing cornea work, they can insert in the cornea ring. Basically, when you put the rings, what's happening, you're creating like a new limbus by elevating the periphery, and that's will flatten the center. It adds also another strength to the cornea. So one advantage of the ring is add more extra strength to the cornea and improve the shape, improve the high order aberration, reduce the stigmatism, reduce the defocus myopia, and also some patient who do not tolerate contact lens, by putting a ring, because improving the bulginess, that patient may become comfortable and can be tolerated contact lens. And by putting the rings, that will allow redistribution of the stress in the cornea, and that help to improve the quality, but also add strength to the cornea. We're using the intercorneal ring for a long time. Initially, 1996, that's the first the intercorneal ring license initially to treat myopia, but because we had eczema laser much precise for treat myopia, so people stopped using it until year 2000, that the people start back again using intercorneal ring as a modality to treat keratoconus. So we're using it for very long. It's very safe, effective. One advantage of the ring, it's if its patient doesn't see better or any side effect, it's reversible. You could remove it, like this one. It had irritation and it's overcorrecting. We could remove it. You can adjust the rings. It's had very low complication rate and high patient satisfaction. But really, this patient satisfaction really related to the right choice of the patient. So you need to choose your patient suitable for the rings, and has very fast visual rehabilitation. By doing the rings, hopefully you delay or avoid altogether keratoplasty. The disadvantage is still the predictability is not as good as we wanted. There's a risk of extrusion, especially if the people still rubbing his eye, and you could have a glare if someone had large pupils. So it's very important also to measure the pupil size, and you could use a wider ring if you need it. And if you're concerned about the disease progress, definitely you need to do cross-linking. Ring alone is not a treatment to progressive keratoconus alone. So generally, shall we do it the same time or do intercorneal ring then cross-linking? Personally, using intercorneal ring first, make sure the vision is good, patient happy, then do the cornea cross-linking. Some people using the same time, so different advantage and disadvantage. By doing intercorneal ring and cross-linking, basically what you do, really you improve the larger irregularity with the rings. Then the potential you could wait 6 months, a year, better even a year, then you could use the BTK as fine remodeling, just fine tuning for this patient. So that's, you could do different steps to improve this patient vision. Some people also using after fine tuning, and if someone had still high refractive error, astigmatism, you could consider toric ICL for such patient. So intercorneal ring, so we had long-term follow-up, more than 15 years, is acceptable, reversible, and have very long safety parameter. There's one, Dr. Aliyu, he published data analysis for different paper, almost more than 100 publication paper about intercorneal ring use, and the spherical equivalent reduction mean 1.45 to 3.5. Also, there's a good reduction in the cylinder and the K reading. The nomogram, as I mentioned, you have to choose the right ring for your patient. So there's different nomogram you could use it, taking in consideration the refraction of the patient, topography pattern, sphericity, the coma, and also you could on the table fine tuning or replacing the rings. There's a new emerging design of the rings, which always there's like the progressive ring, which is a thinner in one side, thicker in other area, which can be selected for some patient. The new modality of intercorneal ring is not using a plastic, so we could using a human tissue, the cornea tissue, instead of the plastic ring, and what you call cornea allogenic interstromal ring segment CARES, which is also first published by Susanna Jacob 5 years ago. It shows a good result. I follow her cases. Really, they have a very good, amazing result. But still, because there's no fixed nomogram, still you need to do manually cutting. Although some people using femtosecond laser, but you cannot custom made yet the thickness exactly. So hopefully, very soon, some of the company using femtosecond laser can allow us to adjust the parameter to get a better shape, and we have better nomogram for this. The good things, because it's a cornea tissue, so it's compatible more, and there's no risk of extrusion or inflammation. So really, it's a very good tool modality. I'm looking forward to the newer development of that. And this is a OCT scan compared the BMMA intercorneal ring and the allogenic graft. look into some of the cases like this one of my patient. He had keratoconus, cannot tolerate contact lens. So basically, I put the rings, 2 segment, and this for this patient you have usually if asymmetric cornea, we put the thicker segment inferior and the thinner superior, and use different mammogram to put the rings. And this is, you could see before and after the intercorneal ring, there's a huge improvement in the patient. All astigmatism 3.5 to less than 1 diopter. Unaided visual acuity improved significantly from 2400 to 2025, and the refraction, the Q value, all improving. Same things with the other patient. This is asymmetry because the refraction is not high, so it's for astigmatism only. So we put 1 ring only, and that's improving his astigmatism to become 1 diopter only, improve the Q value, and improve the unaided visual acuity and best corrected visual acuity. After he's happy with 1 eye, I did the other. Always I don't do both eyes at the same time. So for rings, so do 1 eye and maybe learn from the result of the first eye to adjust it for the second eye. And after 3 months from the intercorneal ring, and the patient happy, I did the cross-linking both eyes and then monitor him over years, and he's very happy, everything is stable. This is another case also, asymmetry, and we have to put the mammogram because it's high astigmatism, -2, -9 astigmatism. I use 2 rings, asymmetry, and that's improved his vision and improve the out refraction to 1.75 astigmatism. So it's a big improvement for patient quality of life and manage it, and just he can wear glasses, very small glasses, and he can enjoy life without the need for any further procedure. This is the other eye for the same patient. So conclusion is keratoconus management need to be custom to the patient's stage of keratoconus, contact lens intolerance, if you have a scar or not, and what patient expectations. So you cannot have one treatment like just do cross-linking and fit everyone. So you have to fit too many modality, and you choose the right treatment for the patient. Surgeon need to have a clear plan of management. So you need to alter the patient, put the rings, and if it's improving, then we do the other eye, and then I do cross-link. So always you have stages, what the plan, if it's not better, what to do. You need to have different options, as we said. Intercorneal ring is a very effective way to treat keratoconus, improve the vision for grade stage 1 to 3. And you need to choose the right rings selection. Femtosecond make it much easy, better, safer, and predictable. And as we know, the intercorneal ring add strength to the cornea. Better generally to do intercorneal ring than do cross-linking. Regarding cross-link is a very effective way to stop the progressive disease. I think in future, I think the corneal graft volume become much less. So hopefully we don't need to do any corneal graft in future for anyone had keratoconus, because really cross-linking and monitor the patient is a very effective way, and hopefully will stop all the keratoconus to progress to a later stage. In selective cases, you could do topo-guided BTK. As I mentioned, the idea to improve the vision, but still the patient need the glasses. ICL is another modality. You can use it for people who had high astigmatism or high refractive error, especially anisometropia, but make sure that the patient can see reasonably well with the glasses. If someone cannot see with the glasses very badly, don't expect it by putting phakic implant, the patient will see clear. So it's different between the patient contact lens, which mask all irregularity, than the glass. So if the patient see well with the glasses, by putting phakic implant, more likely the vision will be the same or even better, but to a limit. Corneal graft, as we say, it's the last option, and always better to do DALK to save the endothelium and make better survival for the graft than to do penetrative keratoplasty. And thank you very much. And sorry it was long.
Thank you, Dr. Osama, for the nice and comprehensive lecture. I have one question here I want to highlight. Keratoconus and the pregnancy. Sometimes you got young ladies who decide they are diagnosed with keratoconus, has been followed up and they were stable. So, and suddenly they decide to get pregnant. Any recommendation for these cases? Would you go and cross-link them prophylactically, or you wait till they document progression? And I know how about cross-linking during pregnancy? Is it relative contraindication?
So basically, consensus now, if someone progressive keratoconus, you need to do cross-linking, even if they're pregnant, with the caution. But if you're not sure, you need to monitor. Because the progressive keratoconus, if it's progressive, and you plan to do cross-linking and become pregnant, there are very high chances that keratoconus become much worse by the pregnancy. And there's no risk factor, the ultraviolet, for the pregnancy itself. There's a concern about steroid a little bit, but you could, and the pain, but is you need to consider and discuss with the patient and the obstetrician about that. Any idea about from Dr. Lucio? What's your feedback about that?
Yes, I
And
follow.
keratoconus, progressive.
Yes, I follow the same idea that you told now. Yes, I follow the rules, the science when we identify the progression of the keratoconus in the image and topography. I indicate, yes, first of all, congratulations for this challenge of bringing all of these topics in 15 minutes. Yes, and it was a great talk, but I completely agree with you. Yes. I want to talk about, push some other points here about pediatric. I really want to know how do you manage, because we know that keratoconus is so aggressive in a pediatric group, yes, and sometimes if okay, we follow to wait progressing, but how do you manage? And when sometimes when we find a thinner cornea, yes, with a thinner thickness of cornea that is not indicated sometimes to perform a cross-link. So how do you manage about this in these groups?
So basically for pediatric, I think most of the surgeon, they agree that below 18, any keratoconus diagnosis, they do cross-linking. They don't wait until demonstrated progressive. Some people, if you want to watch it also, you need to watch it very closely, but caution about it because really they can progress very quick and that's the problem. Regarding if it's very young, some people do it under GA. Usually the youngest one I did 12 years and the 12, I did it under topical. It was a cooperative child, okay? But if you need it, you can just put it the GA and then do the cross-link. But I think it's because they can progress very quick and you may lose the patient and come to you late. So there's a very concern about pediatric. And generally, I do cross-linking if I had pediatric patient.
Yes, my question was just to provoke, yes, to bring two possibilities, yes, to make the cornea stable. One of them is cross-linking, and another one to not forget is the Baumann keratoplasty, yes. Sometimes we find the thickness around 200, 250, and we are afraid sometimes to perform a cross-linking. I completely agree that if it's possible, go to cross-linking, the first options, yes, but that we don't have the thickness, yes, to perform. And I remember one case that I in one pediatric, children with can you hear me? Yes, I think it stopped.
Yeah,
no?
We can hear you.
Yes, okay. This child, she was 11 years old, 11, and 200 microns in the center of the cornea, progressing the keratoconus, keratometry around 68. Oh my God! So I was afraid to put in a femtosecond later to perform a Baumann keratoplasty, but I talked with the mother, with a good conversation. We get into the surgical room, and it went very well. Yes, and so it's another option to stop sometimes, not to recover the visual, the vision, but to stop. And this patient, I have 4 cases. I don't have so much. I have 4 cases of Baumann keratoplasty, and with follow-up more than 1 year. And I noticed in some case a little bit flattening of this cornea that avoided keratoplasty, Wandalk, and the patients could wear a contact lens and now have a great vision, great not, but maybe as good as possible, a good vision with 20/50, 20/40 with contact lens is another option, another that we could not forget to. Yes, but congratulations.
The other way also the same. It's the Bowman's layer. They're people using the like smile cuts, the stroma. They do bucket and they just and they do interstromal, and then you do cross-linking over it. So by adding tissue and the cross-linking, hopefully that will, if there's no corneal scar, definitely, because if there's a corneal scar, vision not good, then you cannot do much about that. But if it is a no visual scar and synconia, you could add even not the Bowman's, but you could also stroma like a smile piece, or some people now they're cutting the cornea, the anterior one and meniscus one. You put you using a smile bucket and you inserted that and then use a cross-link, and that's another modality. But as I mentioned earlier, hopefully we don't need to reach the stage where the cornea is too thin or scar and you will go to that model. That's why it's a really early diagnosis. Fast action is very crucial.
Great.
I have one question here from one of our audience. He is asking about the protocol in the pediatric patients. Is it epi on or epi off? And which protocol our team will recommend?
Basically, Lucy, do you want to answer that?
No, come on, go. It's a topic, your talk.
That's okay, that's fine. We can cover both this discussion. So there's no, basically epithelium off is better way to have stronger cross-linking, okay? Especially with the pediatric. But the problem with epithelium off is the pain and the discomfort, okay? It's still up to now, which is even last week meeting in ESCRS, it's still, there's a debate about it. There's no good, still good epithelium on riboflavin, you need the oxygen. So it's very variable. So you could do epithelium on, but you need to monitor this patient more because the chances of the maximum stiffness is less. So if you can do epithelium off, I think there's more chance to have better cross-linking for the child. If you do,
Okay, and regarding
sorry?
Regarding the protocol, accelerated 10-minute is acceptable, I think.
I think it's acceptable, equal to the 30-minute, okay? Now with the accelerated, cross-linking is very close to the Dresden protocol, and for children to keep them half an hour is too long, really. Okay,
I do agree, and this is lead us to another question from our audience. Dr. Lama is asking how many times we can repeat cross-linking in progressive keratoconus.
There's no limit,
Yes.
up to my knowledge, but if it's a progress and still cornea clear, that's where the maybe if you did epithelium on and progress, you have to do epithelium off. Okay.
I do agree.
Yes, oh, sorry.
I just want to conclude by highlight one point in special category of patients. From real life practice, those are the kids with Duane syndrome, trisomy 21. Those kids tends to have a high prevalence of keratoconus, and they are not fully aware to express and to express that they are not seeing. So for all our colleagues who are seeing those patients, please just try to do at least once a year corneal tomography. And if you suspect keratoconus, they are nice kids. Usually we can manage them. We can do cross-linking and save their size, because I've come across my practice to see cases with advanced cases, and for this special category of patient, keratoplasty is a nightmare, because they are not quite fully aware, and they might rub their eyes, especially if a lot of problems happened when you come to reach the level of keratoplasty in these kids. So this is one note from my practice, and I want to hear from our colleagues about their experience as well.
Well, I just want to add one information about the cross-link pediatric, because I completely agree. I made with off epithelium. Yes, I make it off epithelium. I know that we have increased the risk of infection, the pain, but I want to stop the increasing of the disease in the pediatric. That's my goal. That's my purpose. Yes, and I really completely understand the concern about the standard crosslink with 30 minutes because as we know, sometimes it brings some irregular flattening of the cornea and worsening the vision, and sometimes leaving some scars. But it's a game changer, the fast crosslink nowadays. I think it decreased a lot the numbers of complications. And of course, we need the protocol to indicate when we find in the pediatrics, for example, mainly as we're talking about, a progressive, a steepening, a worsening the vision, and okay, let's indicate. But it's completely different nowadays with when you have a fast crosslink, the standard, because in my experience, in some papers shows the less inducing complications with the fast one. And I read some papers that shows that even that children that underwent to a crosslink because of the more elastic and remodeling the collagen, they developed, they take stable during for 4 or 5 years, and after then they could develop again keratoconus. And if you identify again, go in performance again this crosslink. So I think we need to say these 2 points, yes, compare the fast and the standard, and in the risk of losing vision in this group in the pediatric group, yes, of not doing.
Thank you, Dr. Usman, for your nice comment.
Yeah.
Any more questions from the audience before we conclude?
I think Dr. Ahmad or Dr. Osama, there is someone raising hand. I don't know if the management can allow the raised hand to be with us.
Fine for us. It's you can with this question, or you can put the mic to him.
Okay. If you don't have any other comments, last comment from Dr. Licio or Osama?
I think one comment from my side, really, it's just always very important. I find some patient doctors, they don't mention about contact lens as an option, okay? I think contact lens is still the best vision for keratoconus is contact lens. So always we need to explore that the patient fitness of contact lens, not to jump for the rings or cornea graft. So contact lens, that's if you have the good service, good fitting, really it's a good modality to improve the vision. Even in our area, people think, oh, it's dusty environment, other. If once the patient wear contact lens and he can see 20/20, he's the one will insist to keep the contact lens. So because if you tell the patient to have contact lens, sometimes he denied that he wanted to, but once he see very clear that the vision, just try to push him to try. So when he try and he can see clear, that's the motivation he will the one ask for.
Yes.
Yes, I do agree. And I have one request for all of our colleagues. Please, when you have a child who is not reaching 20/20 and with high astigmatism, please do request a corneal tomography, because you might save the sight of this child if he diagnosed early.
Yeah, definitely yes. And the family here, especially anyone had family keratoconus, all the family need to screen it.
Yes.
So that's what I tell them. Just go do screen at least peace of mind. Don't wait until you had too much problem. At least you had the baseline also. At least if it's even later you had something change, when you do scan, at least you had the baseline how it was before.
Exactly. Exactly, Dr. Osama.
Yes, it's important comment. Yes, ask for to come all the families to be analyzed. Yeah.
I think all question answered, because I think there is one comment. We know that the new protocol of the ultra-thin cornea. May we know what is the
I think
protocol?
it has been answered by Dr. Osama's slides.
I think it's just, yeah, if they go to search for ultra-thin, there's protocol, which you can find it in the publication by Mazzotta, or go for Fahidi, one for ultra thin protocol, and you can see the nomogram, which one have to adjust the energy. There's one question here, which procedure is more accurate? The cornea ring plus cornea cross-linking, same session or separate? Basically, is the same result, but what one thinks you can, if you do intercorneal ring and cross-linking, the patient next few days to a couple of weeks, he cannot see clear. So you don't know, is this ring was good for this patient or not? So, and that's why if you put the ring first, you know that the shape is good and improve with the shape. Then if you're happy with the vision, then I do cross-linking to stiff that shape, you know what I mean? But I know it's two procedure, but the effectiveness is the same almost, but you don't know when you do both together, you don't know until very late to know this ring did some better job or not. I'm not sure, but it's both, the option is there. What do you do, Dr. Lucio and Dr. Mohammed? Do you do the same or you do separate for rings and cross-linking?
Yeah, it's a good question, because I read one paper that studied the efficiency about performing before, at the same time, or separating, or doing before the rings, or after, or before the cross-link. And the paper shown that has no difference, the results in the outcomes, if you perform together or separated. It depends on the surgeon, the preference of the surgeon, but in my case, of course, if I can do at the same time, sometimes the patients live so far from here, we have difficulties to come. Yes, and if we can do at the same time, it's okay. But if I split the procedures, I prefer to put primarily intact the rings. Yes, because I don't know, but I give to the patient the sensation of, oh well, wow, the faith, wow, yes, I got better my vision now. Yes, and then you got the confidence, the patient trusting you. Okay, you got some results that now I'm seeing better, and then I go to the cross-link in the second time. That's the way I do here.
I totally agree with my colleagues. If I have the chance, I would inform the patient we need to regularize the cornea before fixing it, because fixing a regular surface is better than fixing an irregular surface. But sometimes, as Dr. Lucio mentioned, if the patient does not have, for logistic reasons, cannot come frequently, then yes, I might combine them together.
And the second advantage of doing it together, after I do it separate, if they put the rings and the vision improve, but still not as good yet, I could do that topo guided with the cross-linking at the same time to help improve the shape a little bit further, fine-tuning with the cross-linking.
Yes, that's smart idea, Dr. Usama.
Well, sorry, I lose the question.
So sometimes it's the one advantage to do separate. By doing rings, the patient improve, but if improving, but not as good yet with the glasses, when I do cross-linking, I could do BTK with the cross-linking to improve it a little bit further. So more fine-tuning.
Yes, sorry, if I perform the rings and the patients got not a good vision, that's what the question. If I wait, go to progressive.
It's a comment. I said, it's a comment. If they put the advantage to do the ring first, make sure the patient vision is better.
Yes.
Then do cross-linking.
Yes.
But when you put the rings and the patient see better, but not yet as good as we wanted, you could still do topo guided with cross-linking to refine a bit further.
Yes, I completely agree. Yes, I think we could have this effect. Yes, with taking first the rings, you gain the patience. Yes, we will improve the visions. Yes, and well, I really follow this patient if we will progressive or not. If progressive, of course. Our progressive indicate, as we said now, the cross-link. But one important thing that we should say about the vision in the rings to the patients is that it's not a refractive surgery. It's a therapeutic surgery. Yes, that's an important point. We're treating one disease. We are trying to to make better the surface of this cornea, the regularity of this cornea. Yes, it's not to take out all the ametropy and put in zero, and it's not a refractive surgery. That's the point that I really bring to the conversation, the chair time with the patients. The patient must know that he will improve. Yes, we're trying to improve, putting some rings, but we left some refractions, and with better regularity of the cornea, it could improve better their vision. That's important point. Not a refractive surgery, but a therapeutic surgery. Yeah.
I think there is one more question came now. And can we consider that if the thickness less than 400, can we do linking with epithelium off?
It's the same. We mentioned that there's different protocol. You could set the energy and the duration, and you could do it below 400. Depends on what way you're using. And you could still using, if you don't want that protocol, you could use hypotonic saline, riboflavin, hypotonic, and you swallow the cornea. You could use the contact lens. There's different modality, and just you need familiar with different modality available, and you can choose what's comfortable option you want to do.
Yeah, the same, I do.
Yes, I do agree with that.
We can come to the end of this meeting. Thank you very much, Dr. Osama. Thank you, Dr. Yusuf, for being with us. Thank you, Dr. Muhammad. It was a great learning from all of your experts. I know this keratoconus is a huge or a big things that to talk about it in just 1.5 hours or almost less. It needs a lot of webinars or many sessions to discuss all the points, but I think we have come across all the points that's very important to be noticed by everyone is dealing with keratoconus. Thank you for all your time, and thanks for the attendees for being with us until this time. And I would like also to welcome all the attendees to our 5th MIOM and first Presmina conference that will be from 19 to 21 of October in this year in Dubai. And waiting to see you, inshallah, maybe in the coming weeks in another webinar. Thank you and good night. Thank you very much.
Thank you and
Assalamu
goodbye.
Thank you very much.
Thank you.
Bye-bye.
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 Thank you.
Thank you.